Hello everyone and welcome to this InpharmD CE Masterclass, where we aim to eliminate redundancy in drug information to drive evidence-based care. I'm your presenter for today's topic, Scott Perkins. Our CEs are developed from commonly asked questions that we receive here at InpharmD. We have a database of well over 10,000 drug information requests, and the data that we've gotten from that database indicates that there's roughly a 40% chance that if you have an inquiry that someone else has already asked for that same information. So in our CEs, we hope to provide insight on topics providers are clearly interested in and possibly answer questions that you may have before you even send them our way. Now, if you have a specific topic that you'd like for us to cover, don't hesitate to reach out to Janvi here at InpharmD. Her email is janhavi@inform.com. Today's slides were developed by Janvi Punyarthi, a pharmacist and director of brand development at InpharmD. And I'll be presenting today's material. Like I said, I'm Scott Perkins. I'm a clinical associate professor here at Campbell's College of Pharmacy. I also act as our co-director of drug information, and I've been an academic partner here with InpharmD for the past several years. Before we jump into things today, neither Janvi nor myself have any relevant financial disclosures to make as they pertain to the material in this presentation. Our learning objectives for today are to explain the presentation and effects of RSV, to outline the indications, use, and dosage for RSV vaccines, to identify pertinent pharmacology and clinical characteristics of RSV vaccines, to review comparative efficacy between approved RSV vaccines, and finally to discuss how the data on the new RSV vaccines can impact clinical practice. Incidence of RSV has risen over recent years. The virus causes seasonal epidemics of respiratory illness and it can be especially devastating for older adults. Each year, it's estimated to result in a staggering 60,000 to 160,000 hospitalizations and 6,000 to 10,000 deaths among adults who are aged 65 years or older in the United States alone. Certain groups within the older adult population are particularly vulnerable. Those with specific medical conditions, those who reside in long-term care facilities, individuals who are frail or of an advanced age, or those who have compromised immunity, they all face a higher risk of severe disease and hospitalization when infected with RSV. So earlier this year, the Food and Drug Administration granted approval, in fact in May of 2023, for the first RSV vaccines. Now these vaccines are specifically designed for the prevention of RSV-associated lower respiratory tract infections in adults aged 60 years of age and older. There are two approved vaccines. One is Arexvy, which is the RSV pre-F3 vaccine, which is an adjuvanted recombinant stabilized perfusion F protein pre-F vaccine developed by GlaxoSmithKline. And then there's Abrysvo, which is a recombinant stabilized pre-F vaccine developed by Pfizer. It's noteworthy that most adults who contract RSV experience only mild or they experience asymptomatic infections. These infections typically manifest as nonspecific upper respiratory tract symptoms such as rhinorrhea, sore throat, a low-grade fever, and they typically resolve within 1 to 2 weeks. RSV is primarily transmitted through direct contact with respiratory secretions, fomites, and large respiratory droplets. The Centers for Disease Control and Prevention recommends that adults aged 60 and older can receive an RSV vaccine with the decision to vaccinate based on shared clinical decision-making between healthcare providers and patients. This decision takes into account the patient's risk for severe RSV, their specific characteristics, values, and preferences, as well as the healthcare provider's clinical discretion and the characteristics of the vaccines themselves. Vaccination is particularly beneficial for individuals with chronic medical conditions, including lung diseases such as chronic obstructive pulmonary disease and asthma, cardiovascular disease such as congestive heart failure and coronary artery disease, diabetes mellitus, neurologic disorders or neuromuscular conditions, kidney disorders, liver disorders, hematologic conditions, those who are frail or of an advanced age, or have other generally underlying conditions that increase the risk of severe RSV-associated disease, like residing in a nursing home or a long-term care facility. In cases of RSV infection, supportive care is essential. This includes fluids, antipyretic agents, supplemental oxygen, and in certain situations, bronchodilators and corticosteroids, which can also be very useful. This is especially true for patients with acute wheezing, such as those with asthma or chronic obstructive pulmonary disease. Now, in addition to that, there's also some pharmacologic therapy. The antiviral medication ribavirin is sometimes used, although it's important to note that it doesn't have an FDA-approved use for the treatment of RSV infection in adults in the US, and its efficacy is somewhat subject of debate. So now let's take a closer look at the vaccines themselves. Both vaccines are approved for active immunization for the prevention of lower respiratory tract disease caused by respiratory syncytial virus in individuals 60 years of age and older. However, Abrysvo carries a second indication for the active immunization of pregnant individuals at 32 weeks through 36 weeks gestational age for the prevention of lower respiratory tract disease and severe lower respiratory tract disease caused by RSV in infants from birth through 6 months of age. The window of vaccination is fairly short. It's a 5-week window, but does provide an advantage for the vulnerable infant population. Once reconstituted, both vaccines need to be administered immediately, though both provide for a 4-hour window at which they can be stored at room temperature. No data are currently available to support Abrysvo's administration with other vaccines. However, Arexvy was studied in a multinational phase 3 trial with concomitant administration of the quadrivalent flu vaccine, the live vaccine. In total, nearly 450 patients received concomitant vaccination, and the study authors found no evidence for interference in the immune response to any of the antigens contained in both concomitantly administered vaccines. Currently, this is the only published study regarding concomitant administration of RSV vaccines with other vaccines. Neither of these vaccines are live vaccines. However, one important difference is that Abrysvo's vaccine is formulated with the addition of an adjuvant, whereas Arexvy does not have this component. Efficacy between these two agents has not been compared directly. However, they have both included trial data from patients who are 60 years of age and older. Arexvy reduces the risk of infection by 82.6% and severe infection by 94.1%. The risk of developing the first episode of RSV with Abrysvo is 66.7% for more mild infections and 85.7% for more severe infections. Severe infections are defined by 3 or more symptoms that are experienced by the patient. Both products also come with warnings for vaccine allergic reactions, syncope, and altered immunocompetence. In case of anaphylaxis, both of the manufacturers indicate that appropriate treatment and supervision should take place after administration. Fainting is said to potentially occur following administration of both of these drugs, and administration should occur in a location that prevents injury in case of fainting. While neither of these vaccines are live vaccines, it's important to note that immunocompromised patients due to illness or really immunosuppressive medications, that these individuals may have a diminished immune response to these agents. Abrysvo also carries a risk for preterm birth. Now, remember, this is the agent that is approved for use in pregnancy between weeks 32 and 36 of gestation. Labeling states that a numerical imbalance in preterm births in Abrysvo recipients was observed compared to placebo recipients. This is observed in 2 clinical studies. Available data are really insufficient to establish or exclude a causal relationship between preterm birth and Abrysvo. To avoid the potential risk of preterm birth with the use of Abrysvo before 32 weeks, we should administer Abrysvo as indicated in pregnant individuals at 32 weeks through 36 weeks of gestational age. Pregnant individuals who were at increased risk of preterm birth were generally excluded from these clinical studies. So that's important to note. Now, interestingly, adverse events appeared to vary a fair amount between these agents when we studied them in clinical trials. Although most reactions to these agents are common amongst many different vaccinations. Arexvy had higher rates of injection site pain at nearly 60.9%, and nearly 1 in 5 patients reported arthralgia. And arthralgia was not noted with Abrysvo. Higher rates of fatigue, myalgia, and headache were also noted with Arexvy. Adverse effects in those who were pregnant were more commonly twice as high as it was for individuals greater than 60 years of age. We saw a lot more side effects in those pregnant patients. Now, we've talked a little bit about the use of Abrysvo in pregnancy, but the product labeling states that data from clinical trials in pregnant individuals who received Abrysvo 24 through 36 weeks of gestation revealed no evidence for vaccine-associated increases in the risk for congenital abnormalities or fetal death. In this study, there was a numerical imbalance in preterm births, with more preterm infants born in individuals in the Abrysvo group compared to individuals in the placebo group. So Abrysvo has not been studied in pregnant individuals less than 24 weeks gestational age and those at increased risk for preterm birth. While Arexvy is not approved for those who are pregnant, it's important to note that a clinical trial was conducted that enrolled this patient population. Unfortunately, this agent was more clearly associated with an increase in preterm births. In terms of administration to other special populations, neither agent has been approved in the pediatric population. In fact, animal models have suggested that Arexvy would likely be unsafe to administer in individuals younger than 2 years of age due to an increased risk of respiratory disease. No data exists for either agent in populations 17 years of age or younger. In terms of geriatric populations, clearly these agents were well studied in patients ranging from 60 to 80 years of age or older. In terms of storage, neither agent should be frozen, but they should both be stored in the refrigerator. As I mentioned earlier, both can be stored at room temperature once reconstituted for up to 4 hours. All right, now let's take a look at the literature involving these two agents. First, we'll look at the data around Arexvy, the RSV pre-F3 agent. This agent has been evaluated in a phase 3 international trial that has included nearly 25,000 patients and is still ongoing. Authors sought to show a vaccine efficacy of 1 dose of the RSV pre-F3 vaccine against RSV-related lower respiratory tract disease, confirmed by reverse transcriptase polymerase chain reaction, or RT-PCR, during one RSV season. Subjects were randomized to the study group or placebo group at a rate of 1:1. Patients were included if they were 60 years of age or older, and they were medically stable at the time of the first vaccination. Those excluded from the study had confirmed or suspected immunosuppressive or immunodeficient conditions resulting from disease or immunosuppressive or cytotoxic therapy based on their medical history and physical examination. A history of any reaction or hypersensitivity likely to be exacerbated by any component of the vaccine. Hypersensitivity to latex, serious or unstable chronic illness, history of dementia or any medical condition that moderately or severely impaired cognition, recurrent or uncontrolled neurological disorders or seizures, planned or actual administration of a vaccine not foreseen by the study protocol in the period starting 30 days before each dose and ending 30 days after each dose of the study vaccination administration, with the exception of inactivated and subunit influenza vaccines, which could be administered up to 14 days before or from 14 days after each study vaccination. And finally, patients were excluded if they had previous vaccination with an RSV vaccine. Patients were assigned to groups prior to the beginning of RSV season. Respiratory infection surveillance was reported spontaneously by the participant or by means of scheduled contact with the patient. Enrollment began in May of 2021 and ended in January of 2022. The median follow-up time was 6.7 months, with a maximum follow-up of 10.1 months. The authors evaluated vaccine efficacy against TR-PCR confirmed RSV-related lower respiratory tract disease during one season as their primary endpoint. Efficacy against severe RSV-related lower respiratory tract disease, acute respiratory infections, and efficacy against RSV-A and B subtypes were also evaluated. Let's take a closer look at the results of the clinical trial. Over a median follow-up period of 6.7 months, a total of 47 patients reported experiencing RSV-related lower respiratory tract disease. Among them, 7 were from the vaccine group and 40 were from the placebo group. Thus, the vaccine demonstrated an impressive efficacy rate of 82.6%, with a confidence interval ranging from 57.9% to 94.1%. This suggests that the vaccine was highly effective in reducing the risk of RSV-related lower respiratory tract disease. When authors specifically looked at severe cases of RSV-related lower respiratory tract disease, considering clinical signs or investigator assessments, the vaccine's efficacy skyrocketed to 94.1%. In practical terms, this means there was only one case in the vaccine group compared to 17 cases in the placebo group. A total of 122 participants, including 27 from the vaccine group and 95 from the placebo group, experienced at least one episode of RSV-related acute respiratory infection. The vaccine demonstrated a strong efficacy rate of 71.7% in preventing these infections, with a confidence interval ranging from 56.2% to 82.3%. Side effects were experienced by nearly 72% of the patients in the intervention group. The most common side effect was any pain, which occurred in nearly 61% of the patients taking the study drug. Other common side effects included fatigue at 33.6%, myalgia at 28.9%, and headache at 27.2%. All of these adverse reactions occurred at rates higher than the rates experienced by the placebo group. In terms of serious adverse events, the rates at which these occurred did not statistically differ between the intervention group and the placebo group. Any serious adverse event was experienced at a rate of 4.2% in the intervention group and 4.0% in the placebo group. Again, the difference here was not statistically significant. The rate of fatal serious adverse events was 0.4 in the intervention group and 0.5 in the placebo group. Again, these results were not significant. The same can be said about unsolicited adverse events, with grade 3 adverse events occurring at roughly the same rate between both groups. Adverse effects related to immune-mediated disease were again roughly the same between both groups, and the difference was not statistically significant. The authors of the study concluded that a single dose of the RSV pre-F3 OA vaccine had an acceptable safety profile and prevented RSV-related acute respiratory infection and lower respiratory tract disease, and severe RSV-related lower respiratory tract disease in adults 60 years of age or older, regardless of RSV subtype and the presence of underlying coexisting conditions. It is important to recognize that the trial has several limitations, including the relatively small number of participants aged 80 years or older and those who are frail. Additionally, the ability to detect rare side effects among patients was limited. The operational challenges were further compounded by conducting the trial during the second year of the COVID-19 pandemic. Furthermore, public health measures implemented to control COVID-19 led to a decrease in RSV transmission and changed the timing of the RSV season. As a result, most RSV-related acute respiratory infection cases occurred earlier in the season than anticipated. The efficacy and safety of Abrysvo was evaluated in a study titled Efficacy and Safety of Bivalent RSV Prefusion F Vaccine in Older Adults. The study is an ongoing, randomized, placebo-controlled Phase 3 trial, which has included over 34,000 patients. The authors sought to evaluate the efficacy and safety of the bivalent RSV Prefusion F protein-based vaccine in the first RSV season after injection. In total, 17,215 individuals were randomized to the intervention group, and 17,069 individuals were randomized to the placebo group. Patients were included if they were 60 years of age or older at the time of the first study intervention administration. Patients also needed to be healthy with stable pre-existing disease. Patients were excluded if they were immunocompromised, apart from stable human immunodeficiency virus, hepatitis B virus, or hepatitis C infection. Patients were excluded if they had bleeding diathesis or a condition associated with prolonged bleeding, a history of severe adverse reactions associated with a vaccine and or severe allergic reaction such as anaphylaxis to any component of the study intervention or any related vaccine. Eligible patients were randomized 1-to-1 to receive one intramuscular injection of unadjuvanted RSV pre-F vaccine at a dose of 120 micrograms, or placebo. To match the appearance of the RSV pre-F vaccine, the placebo injection was lyophilized without the addition of active ingredients. For efficacy measurements, RSV infection was confirmed by means of reverse transcriptase polymerase chain reaction, or RT-PCR assay, or by means of nucleic acid amplification test if RT-PCR testing was unavailable. Testing was performed 7 days after the onset of signs or symptoms. The interim analysis data cutoff date was July 14, 2022, and the mean follow-up was 7 months. The primary outcome measure was vaccine efficacy against seasonal RSV-associated lower respiratory tract illness with at least 2 or at least 3 signs or symptoms lasting more than 1 day. In other words, cough, wheezing, sputum production, shortness of breath, or tachypnea. Authors evaluated the relative risk of a first episode of RSV-associated lower respiratory tract illness in the RSV pre-F vaccine group as compared with the placebo group in the first RSV season, starting on day 15 after injection. Authors also evaluated vaccine efficacy against RSV-associated acute respiratory illness and evaluated safety endpoints as well. Patients in the RSV pre-F vaccine group experienced 11 incidences of RSV-associated lower respiratory tract illness with greater than or equal to 2 signs or symptoms. This equals 1.19 cases per 1,000 person years of observation. Patients in the placebo group experienced 33 of these events, resulting in 3.58 cases per 1,000 person years of observation. Thus, the vaccine efficacy was determined to be 66.7% for RSV-associated lower respiratory tract illness with greater than or equal to 2 signs. Patients in the RSV pre-F group experienced 2 incidences of RSV-associated lower respiratory tract illness with 3 or more signs. In the placebo group, 14 individuals experienced RSV-associated respiratory tract illness with 3 or more signs. This resulted in an 85.7% vaccine efficacy rate for RSV with 3 or more signs. Finally, when evaluating acute respiratory illness, those in the RSV pre-F group experienced 22 of these events, whereas the placebo group experienced 58, for a vaccine efficacy rate of 62.1% for RSV-associated acute respiratory illnesses. In terms of adverse events, local reactions occurred at 12% and 7% in the intervention group and placebo group, respectively. Systemic events occurred in 27 and 26% of patients in the intervention and placebo group, respectively. Serious adverse events occurred at 2.3% in each group, with 3 cases considered to be associated with the trial intervention. The first event was a delayed allergic reaction 7 hours after the injection. The second event was a combination of diplopia, paresthesia of palms and soles, and oculomotor and abducens nerve paralysis 8 days after injection of the vaccine. This patient had a medical history of diabetes mellitus. This event was retrospectively diagnosed as being consistent with Miller-Fisher syndrome, a subset of Guillain-Barré syndrome, characterized by ophthalmoplegia and ataxia. A spinal tap and nerve conduction studies were not performed, and the participant recovered. The third event was a myocardial infarction that developed 6 days after the injection of the vaccine. This individual then underwent angioplasty and later received a diagnosis consistent with Guillain-Barré syndrome that began 7 days after the injection. The authors concluded that the RSV pre-F vaccine prevented RSV-associated lower respiratory tract illness and RSV-associated acute respiratory illness in adults aged 60 years of age or older, without evident safety concerns. It is important to note that patients that were older and frail, above the age of 80, remain underrepresented in this trial, limiting the generalizability of study results to this population. Given the interim analysis of the current report, the long-term efficacy and safety of RSV pre-F vaccine requires further investigation. Additionally, the need for revaccination to maintain and boost immune responses remains unknown. Let's end this session with a brief review. Our first question is, what is not a sign or symptom of symptomatic RSV? Is it sore throat, mild fever, syncope, or a runny nose? And the answer is C, syncope. Syncope is not a sign or symptom of symptomatic RSV. Our next question is, what patients may benefit from an RSV vaccine? Is it A, patients with chronic medical conditions? B, patients residing in a nursing home? C, patients who are frail or advanced in age? Or D, all of the above? Our answer is D. All would potentially benefit from administration of an RSV vaccine. Our next question is, what is the correct administration dose for Arexvy? Is it A, a single dose of 0.5 milliliters as an intramuscular injection? B, a single dose of 1 milliliter as an intramuscular injection? C, a single dose of 0.5 milliliters as a subcutaneous injection? Or D, a single dose of 1 milliliter as a subcutaneous injection? And the answer here is A, a single dose of 0.5 milliliters as an intramuscular injection. Our next question is, how might an RSV vaccine affect pregnant patients? Is it A, there's no effect on pregnant individuals? B, it could cause fetal abnormalities? Or C, it could lead to preterm births? Or D, could delay labor? Well, it's important to note that Arexvy does not have an indication for administration in pregnant patients. And the data that we do have, while it's still minimal, suggests that both agents could potentially lead to preterm births, which is why there is a restriction around Abrysvo's administration in this patient population between the weeks of 32 and 36 weeks. Our next question is, what adverse event is most common with Arexvy? Is it A, fever, B, fatigue, C, injection site pain, or D, headache? Our answer here for Arexvy is injection site pain, C. This is our most common adverse event. Our final question is, what adverse event is most common with Abrysvo? Is it A, fever, B, fatigue, C, injection site pain, or D, headache? And our final answer is fatigue. Fatigue is the most common side effect with Abrysvo, though it's important to note that both of these agents are generally well tolerated in terms of being associated with relatively little severe or serious side effects. That wraps up our CE for today. Thank you so much for participating and being a part of our CE today.